Welcome to this brief discussion regarding rapid sequence intubation. This is a production of Cody Pre-Hospital Medicine Consulting. In our time together, there are a few things that we will discuss. First of all, we will discuss the reasons for rapid sequence intubation. We will be sure to discuss potential pitfalls to the procedure. Because rapid sequence intubation requires potent medications in order to be successful, we will discuss the pharmacology and dosing of the medicines we are using. Of course, we will discuss the steps in the intubation procedure, and by the end of this, you should understand what to do after your patient is successfully intubated. The first, and arguably most important indication for rapid sequence intubation is failure to oxygenate and/or ventilate. These are patients who are failing in spite of high-flow oxygen or non-invasive positive pressure as delivered by bilevel or continuous pressure devices. The second indication for the procedure is airway protection. These will typically be patients with neurological deficits or significant drug overdoses who are unable to protect themselves from aspiration. A word to the wise: don't check a gag reflex because you may end up causing the patient to vomit and aspirate. If you suspect they can't protect their airway, especially if the GCS is less than 8, then intubation is very reasonable. The third indication for intubation is what is known as anticipated clinical course. Examples of this include dangerous overdoses where you expect the patient to end up intubated, somebody with airway burns where intubating now is better rather than intubating later, or a multi-trauma patient who is slowly becoming less alert. In general, it is better to intubate at the earliest time that you recognize the need or potential need. Let's shift our discussion to pitfalls. Pitfalls are opportunities to injure or even kill the patient. The first pitfall that bears mentioning is anatomy. You learn in school that certain indicators may help you know that a difficult intubation lies ahead. Examples of this include obesity, an inflexible neck, a mouth that doesn't open very far, a short fat neck, less than 2 fingers on the thyromental space, or less than 3 fingers under the chin. Hypoxia is another pitfall. Remember that the oxygen dissociation curve tells us that as the pulse oximetry reading approaches 90%, the patient is approaching a dangerous and precipitous drop in their oxygen levels. The implication here is that they won't be able to tolerate apnea. Do everything in your power to prevent hypoxia. We know that patients who become hypoxic have an increased risk of bad outcomes and death from rapid sequence intubation. Similarly, hypotension sets patients up for post-intubation cardiac arrest. When we intubate someone, we convert them to a positive pressure system and decrease preload. If they are hypotensive before we intubate them, they become even more hypotensive after. This is a recipe for disaster. Pre-oxygenation is of the utmost importance. Do everything in your power to oxygenate your patient. If they are breathing, consider using a flushed non-rebreather mask for a few minutes. Another excellent strategy is to use a nasal cannula at 15 liters of flow. If you have 2 oxygen trees, consider combing the mask in the prongs. If the patient is not breathing well enough, you can bag with them. Although not really the purview of this conversation, many advocate sedating the patient and utilizing non-invasive positive pressure ventilation to oxygenate them as much as possible. Again, your goal is 100%. You won't always be able to get there, but try your best. As mentioned earlier, hypotension is bad news. In addition to oxygenating your patient, it is important to resuscitate them. Remember the mantra resuscitate before you intubate. This means to fix their blood pressure. Start with fluids, and if fluids aren't working well enough or fast enough, then add push-dose epinephrine. This is created by combining 1 milliliter of cardiac epinephrine with 9 milliliters of normal saline. This creates a concentration of 10 micrograms per milliliter, which can be given at a dose of 2 or 3 milliliters every minute or so until the mean arterial pressure is above 65. Induction is the process of using a potent sedative medication to induce unconsciousness. Depending on medication availability and protocols, examples of this include ketamine or etomidate. Each has advantages and disadvantages, so be sure to know about adverse reactions for the medications that you carry. After induction, we will paralyze the patient to allow us to completely control breathing and to have access to the airway for the intubation procedure. Succinylcholine and rocuronium are the most common drugs for this. From a pharmacology standpoint, these 2 drugs are somewhat different from one another. From a practical standpoint, both have an onset of action near a minute. Succinylcholine is short-acting, around 5 minutes, and roc is long-acting, around 45 minutes. Your transport time should dictate the type of paralytic that you use. Remember that SUX is contraindicated in patients with burns more than 8 hours old, with suspected or known renal failure, and in patients with chronic musculoskeletal wasting. Plan your intubation before you paralyze the patient. Know your plan of attack, whether it is direct or traditional laryngoscopy versus using a video device. Make sure backup devices are available. Consider using a bougie, especially if using a direct technique. Adults should not be intubated with anything smaller than a 7.5 tube, and if using the direct technique, a Macintosh No. 4 blade is an excellent approach. Always have a plan for intubation failure. This could be as simple as bagging the patient, could include the use of an eye gel, or could be as drastic as a surgical airway. You should be an expert on all of these, so please practice regularly on training dummies so that your skills are fresh. When stressed, you will function at the level of your training. If you don't train regularly, it will be a low bar. After your patient is successfully intubated, they need to be sedated and their pain needs to be controlled. Remember that paralytics offer no sedation. The use of a long-acting paralytic makes it difficult to assess sedation and pain, so be sure to use the medications liberally. Ideally, your patient will be so sedated, they will think they are in the paradise scene here. From a ventilation standpoint, use end-tidal carbon dioxide to guide what you are doing. Ideally, if a ventilator is available, it should be used. If one is not available, be very careful with bagging as to avoid barotrauma or hypoventilation. In summary, intubation is a procedure that is very dangerous, but is one that can make the difference between life and death. A consistent approach to intubation includes recognizing the patient in need and proactively addressing oxygenation and blood pressure. It's important to know the pharmacology, indications, and contraindications for the medications that you carry. Post-intubation management is equally important and includes sedation, pain control, and appropriate ventilation. Practice your skills, have a plan, and know what to do when things aren't going as planned. Many thanks for listening. I hope you found this information useful. Don't hesitate to reach out with any questions that you have.